Okay, welcome everybody to the Stanford Emergency Medicine faculty meeting. ND is here, yeah. I guess we'll get started and maybe some people will straggle in, and you guys are an enthusiastic crowd, so.
We can circle around. Just have people, so it looks like a lot of people are walking in.
Yeah, you leave and come back. Okay, I'll put my serious face on now. Okay. Hi, welcome. Okay, so I'm just going to reset. Okay, so my name's Carl Prickscheitis. I'm from the Department of Emergency Medicine at Stanford. I'm here with some colleagues who will allow them to introduce themselves as we go. The title of this talk is Duly Noted. So we're going to talk a little bit about the 2023 Centers for Medicare and Medicaid Services Billing Changes and some optimizations for the electronic health record to sort of meet those changes and the billing requirements associated with them. We don't have any relevant disclosures. And the overview, we're going to go through four main things. We're going to talk about, first, what the changes in CMS guidelines mean for documentation, give a little bit of an overview. I didn't include any grids because I'm sure we're all used to seeing those grids, and we don't need to see them one more time. We're going to do a case study talking about some of our experiences, and then go through some adaptations to the electronic health record to better meet the guidelines. And then we're going to have a small panel discussion on the future of documentation and possibly using some AI solutions to help get at some of these issues. So let's go through what these guidelines are. Since 1992, a visit level in the ED was based on a combination of history, physical exam, and medical decision-making. And then in 2023, the ED E&M services changed to being based primarily on medical decision-making. The goal of these changes was to better recognize the cognitive efforts that physicians are putting into caring for their patients and to sort of minimize the documentation burden that some of us were having to meet a certain coding level. With the elimination of history and physical exam as direct factors in selecting those codes, like I mentioned, we're no longer obligated to document a certain number of review of systems or physical exam findings. But I think it's important to emphasize that our specialty societies and sort of good practice in medicine recommend that you still document important physical exam findings and then review systems items that you think are appropriate for medical care. So the three new areas that make up medical decision-making are number and complexity of problems addressed, also called COPA. The amount, and COPA addresses the severity and number of issues we manage during the visit. The second one is amount or complexity of data reviewed and analyzed. This evaluates the type and extent of data we review, like tests and consultations. And then there's risk of complications and or morbidity or mortality of patient management. And that's sort of a category that encompasses what the risk is. Potential risks associated with our management decisions, and then also considering potential complications and adverse effects. COPA, or the complexity of the visit, is categorized into 4 levels, ranging from minimal to high. And it's crucial to remember that the complexity is not just based on the final diagnosis. You have to consider the patient's presentation, the potential for complications, and sort of the overall clinical picture. So it doesn't necessarily tie to what the final ICD-9 or 10 code 10 diagnosis is. It's sort of the complexity of the initial presentation and what you're anticipating and managing. Data is also divided up into 3 categories. Category 1 includes tests we order and review, external notes that we review, and then information from independent historians like family members, emergency medical services. or other data sources. Category 2 refers to interpretation of tests, and those are tests that aren't separately billed. So if you do a unique interpretation, that wouldn't normally be done. And then Category 3 involves discussions with external physicians or other healthcare professionals. And then finally, risk, which talks about anticipating and managing complications. And risk assessment is something I think we do a lot of in the ED. We need to consider the potential for complications and adverse events associated with all of our management decisions, including selecting medications, doing procedures, and even the decision to admit or discharge. And I think one of the large changes is I think we all think about these issues, but actually verbalizing them and documenting them in the note for all those decisions we go through is a little bit of a different practice that requires a bit of learning curve. And this gets characterized as well into minimal, low, moderate, and high. So to effectively implement these new guidelines, we need to understand what those 3 core components are, the COPA, data, and risk, and then each of these components sort of goes together and determines the complexity of the encounter and also the associated E&M code level. And there are some complexities to doing this. There's a selection of the best 2 out of 3 components and some matching. There's that grid I referred to that we can reference if you'd like. And the important thing is having some familiarity about how these elements make up the overall E&M code, because it's easy to neglect one of these components and have a chart that doesn't really represent the level of care and thought that was provided for a patient. We're going to go through more of these in a little bit more detail and go through case study and then some EHR integration.
I'll stand up. Thank you, Carl. I really appreciate the opportunity to speak in Carl's leadership and organization on this. I'm going to talk a little bit about just some of what happened at Stanford specifically, how it impacted us, how we went about change management, and some things that aren't necessarily specifically related to just finances, but actually just kind of change management in general within a group. I do want to just reflect for a second. One of the things that came up today, actually this morning, a friend of mine texted me and said that she had been notified that she'd gotten a $5,000 bill after coming to our emergency department with her kid. And that the insurance company had denied the claim, and they were like, how do I contact Stanford to try to negotiate this? I knew the ins and outs of the story already, and I talked to her, and it was a completely legitimate emergency department visit. But it was just an immediate rejection by the insurance company, which they do. They're not supposed to do auto rejections, but they still auto reject. It's just a fact, and there are organizations within our specialty that are fighting that. But as we think about improving our documentation, and we talk about coding, and we talk about not just putting the final diagnosis, but putting in the differential and things, a lot of times our physicians who are so mission-driven think, wow, this is really going to hurt my patient because now we're going to bill our patient more. And I want to remind you of 2 things. One is the majority of a bill from the emergency department is not the pro fee, it's the facility charge. In fact, you probably run 5 to 15% of the actual fee. The second thing is if your documentation is really poor, that patient who gets that rejection is going to have a lot harder time talking to that insurance company. So I got on the phone with the person this morning and I said, these are the things, I want you to write a letter and I'm going to send you a message that you just cut and paste into your letter to the insurance company. Don't contact Stanford, this is completely legitimate. I didn't look at the chart because that's not appropriate, but the chart is going to be what that insurance company looks at when she emails back about her child and tries to get that legitimate visit covered. So it's not just about billing when we talk about this. So what happened going to our case study? What happened at our academic ED? Well, we are like almost every other emergency department in the country. We have a boarding crisis running at 108% capacity on an average day. You know, we went through the pandemic, right, with this huge increase in our, the walking wounded or the walking ill. We have a complex system with multiple stakeholders involved in the documentation, coding, and billing process, including the university, the health system, our department, and an external coding company. And we have, like most places, we have a varying revenue model, right? So it does make it hard sometimes, especially at academic sites, to compare apples to apples, because there's a lot of different models out there. But how did we get to a point of having real problems? Well, one thing was that the health system had control of our coding and billing process. And that is not uncommon speaking to a lot of our colleagues, right? It's not controlled at the department level. So the health system, we had a coding company that was emergency medicine focused a long time ago. The health system decided they were going to internally take the coding on their hands. They did that, and unsuccessfully. And then they switched coding companies. They switched to an external coding company of their choice, not our choice. And it turned out they didn't have any real emergency medicine expertise, and it is a pretty unique field, without consulting us right before the pandemic started. The reporting structure also was very difficult, right? Because the coding company primarily was working with the health system, and then we would try to get information from both of those. But really, the coding company felt like they were reporting to the health system and not to our department. The communication, which had been regular before, became ad hoc because of the pandemic, where regular meetings that were in person now are remote and then often canceled, because our providers are so busy. And we have a triage mindset in our specialty, just simply, right? We know that when somebody comes in, we deal with the worst first. Well, it didn't feel like the worst that we were struggling to get information from the coding company, not in the setting of the mental health of our providers, the critical need of our patients, our capacity and boarding crises, right? I generally say you can work on two things at a time in life, or as an organization, really focused on two things. And that clearly wasn't in the top two. So we triaged that, not forgetting about it, but just triaged it to a lower priority. And lastly, fear of tainting that academic mission, right? You're never going to go into in front of a bunch of academics, and I'll even add all emergency physicians and care providers, and convince them that the most important thing is making money. They would have chosen a different specialty if that's the case, right? They care about their mission. So when you talk about money over and over again, you talk about coding and this and that, there's this idea that you're going to taint your academic mission. So with that, what's the approach we took? Well, first of all, about 15 years or so ago, I sat in some leadership program, and we were talking about change management. And this is probably the most important thing I think about change management, which is everybody thinks you got to go in and convince people that it's an important thing to change, right? Like, I got to convince the board of directors that we need to change X. That is not true at all. Because the list of things that they need to change, well, it's partially true, I should say. The list of things that they need to change is big. And so your thing can be on their list, right? But if it's not in the top two, it ain't going to happen. So it's got to be important to change, and it's got to be urgent. So it's not I need to change, it's I need to change this now. And so we had to create that sense of urgency. So we used data to create that sense of urgency, both in our department, with the health system, and with the coding company, the external coding company. We recruited them as stakeholders and built teams across those organizations and groups to try to look at the problem. We engaged our providers, right, by giving regular updates at faculty meetings and newsletters and just kind of talking about it. I always like to create a tagline now to create that sense of urgency. And our tagline, I'm sure some of the people in the audience, no margin, no mission, right? Thank you, Judd Hollander, who loves to use that one as well, and a lot of other folks in the past. But no margin, no mission, right? Circling that idea of finances being important for the mission, not just the margin. So then we evaluated the coding process, and how we did that was we identified peer institutions. So the AACEM, or the American Academy of Chairs in Emergency Medicine, keeps a data bank of a lot of this stuff. It's run out of Hopkins. They do an amazing job. So when I go and talk to the health system or to the coding company and tell them, we're getting this work RVU per patient, why is it so lower than we would expect? There is like, well, you're this, and don't, is that really apples to apples? That's more like apples to oranges. So going into the AACEM and identifying suburban, high volume emergency departments that are academics with pediatrics, distributed in similar type environments, and creating our cohort. So that when they said, well, I can say, no, we are looking at our cohort, and this is what they look like. So that's available to all of us through the chairs. And then we went back and said, again, tying that success of change to strategy. And what I mean by the strategy piece, again, is that people aren't always going to say, well, the mission's big and things, but everybody's got something they're trying to accomplish, right? If you're an educator and you're saying, I want to build a more diverse workforce by bringing in diversity candidates for a second look, we need a margin, and that ties to your personal mission, right? If you're a researcher and you want to help get your research off the ground so you can save more patients who have heart attacks, you need that clinical research coordinator prior to getting that big grant. That's margin and personal mission. What we did, we'll wrap up, but what we did was we saw this kind of wavering trend after they moved to the new coding company. We started to see this downslide. Then the pandemic hit and we saw this like fall off. And this is like work RVUs per patient. So some of that fall off, everyone was just assuming it's because we're seeing this higher volume. But when we looked at it, that's not actually true. And the tail end of this is actually the time period at which we changed to the new documentation guidelines. Because there was no prep done by our coding company, no real education, external expertise. Luckily, we went to some of the national organizations to help us with that. And what we've seen is a really nice response to that. And now with the new documentation guidelines, which focus on what you're thinking and not just what you're doing and what you're giving the patient from a medication perspective, but the complexity of your mental work, we've seen a bounce back in our work RVUs per patient nicely, which has helped feed our mission. So let me turn it over to Dr. Brown, who led a lot of this work.
Happy Friday morning, SAEM. Thank you all for coming. For those of you who I've not met before, my name is Ian Brown. I'm the Medical Informatics Director for the Stanford Emergency Department. As being the Medical Informatics Director, for the last 10 years, I have spent my time singly focused on making the electronic medical record useful for clinicians. That's what I do. Okay? The note is for two reasons. It's for clinical care, and the note is for communication. All right, I don't live in a Never Never land. This is talk about billing and how we prepared for it. I know that the note is used for billing. So I was very chagrined when I came into medicine, the entire time I've been here. The note has been used to extract parts that I do not think are essential. Things like the family history, the social history, having to check 10 review of systems. So I was cautiously optimistic when the AMA promoted the use of these new CMS guidelines. The idea is for the physicians to be spending less time documenting behind Epic, more time at the bedside. So let's see how we adapted our EMR in order to get ready for these guidelines. We did two things at Stanford, ways of adapting. I hope these are going to be more generalizable into what other folks use. The first thing that we used is the Epic MDM smart form. Essentially, this smart form is provided by Epic. It has wording directly from the CMS guidelines. And if you check off the boxes in here, it is a coder's worksheet, and you can press a button in your disposition section, and it will tell you what your level of service is going to be. And I think this is a really excellent tool to have. If you do not have a coding company external to you, if you're a small community hospital, We are not those. And it didn't really fit well for us. I believe that it is important, in fact, incumbent upon us to have a note set up to make it easier for the coders in order to determine your level of service. It is not our job to code for them. This did not work for our workflow. People were going back and forth between the MDM section and the rest of the note. Residents were duplicating the work that they were doing. It just didn't happen in a smooth way for us. Instead, we went over to a system where we took our note template. Everybody uses the same note template. They use it all differently, but we all start with the same note template. And we put in these drop-down smart lists. We have 9 smart lists, and in order to determine what's in them, we met with our coders, we met with our compliance officers. We asked ourselves questions, things like, what are our doctors good at? And it turns out we're really good at putting in data reviewed, but we're not so good at putting in COPA or risk. We wanted to ask ourselves things, what is not otherwise obvious? So for data reviewed, it's really obvious if the doctor writes, my personal interpretation of the CT is there's no intracranial bleed. But under the 2023 guidelines, you also get data reviewed points for thinking about your New Orleans, Nexus, PCRN criteria, and not getting the CT in the first place. We don't document as well things that we've never done, right? So now we have prompts for it, which ask these questions for our clinicians to fill in. We've got wildcards to provide the extra documentation that's needed. We have things like limitations to history, independent historian in the section under HPI, and our MDM, discussion with other professionals, independent interpretations. Oh, let's talk about this for 1 second. Discussion with other professionals. Our compliance was really hung up on some specific terminology. They wanted things, it's not consulting anymore. It's now discussed with other professionals. It's not a differential diagnosis. It's things considered in making your diagnosis. I don't feel it's appropriate for our clinicians to have to remember all these buzzwords. Now we have drop-down lists. They're automatically in our note template. Take some of the cognitive load off of our clinicians. We have some, the ones in yellow here, they are optional, things like our social determinants of health, prescription drugs considered but not provided, things that you otherwise wouldn't put in there. And this is how now we go forward in collecting this information in our notes. Made a few other changes in our note templates. In our critical care attestation, there are now vanishing tip sheets where when you're in your note, you can click on them and it will show you some tips on how to document your critical care. CDS, remember we said that things like, things that you didn't do, we still get points for. So now things like port score. I've considered omitting a patient. I did for pneumonia, I did a port score, it's 35. They're good for going home. We have links to document that directly from our note template. I made some other things, changed around our attestations. 50% of the patients we admit at Stanford to the ICU do not have a critical care attestation. That's wrong, all right? We've done the work and we're not getting appropriately reimbursed because we choose the default of NA for our critical care smart list. So now we have variable smart lists depending upon what happened. If you admitted somebody to the ICU, if you intubate somebody, if you start on pressors, the choices are different in the drop-down boxes. So now that's what we did. I am concerned that my doctors were going to need to work more. So we wanted to keep a close eye on this. The top part is the amount of characters per patient for residents in red, attendings in blue. The bottom is the total time spent in the notes section of EPIC. And you can see that we actually had a decrease in the amount of characters that were brought into the chart by the residents. Attendings, we didn't change our practice a whole lot, but that's okay. The residents do most of the documentation, and the total amount of time that we spend in the note section also went down a little bit in our emergency department. So applying these changes to comply with the 2023 guidelines, we're actually working less, we're documenting less, and maybe we are accomplishing the goal that we're shooting for. So how did this affect us, the 2023 guidelines, as far as billing is concerned? This is a stacked area chart for our E&M codes. Level 1s at the bottom are in red. It goes up to level 5 in the blue. Critical care is in the purple over there. And when the 2023 guidelines hit us, we actually, you're taking pictures. This is, all right, yeah, I guess it's all public. It's on the website. I feel a little funny. This is our billing data, but that's cool. Our level 2s went away appropriately, like they should have. We were expecting that, and they went to level 3s. However, the level 3s started eating our level 4s, and we just didn't see benefits for our E&M coding after this. Okay. But now what we have is a data source. We were tired of taking the data from the coding company and taking it back to the coding company and saying what's going on here. We developed an independent data source so we can keep an eye on our E&M coding as we go forward. And Matt looked at this and said, well, we've got this big chunk of E&M level 3s, 99283s are too big, took MRNs, went back to the coding company and said, maybe gave some education to them why we thought that these should be level 4s. And if we were missing things in our documentation, we could come back and change our note templates. And through this iterative process, taking independent data and going back and forth with our coding company, we were able over time to make significant benefits. Our level 5s are getting bigger, our 2s and 3s are going away, and we've made some significant progress through this process. It's been working well. Our next step is about providing precision feedback to our clinicians. Now that we have an independent data source, we know how much RVUs our individuals are making. I've blinded the names in order to protect the innocent, so you are welcome to take photos, because many of those people are in the room today. And we know who's getting the RVUs per patient. We know the high points, the low points. We're able to give feedback. We don't necessarily give all of this to our clinicians. We're only now focusing on our critical care, because you don't want to overflood folks. But as administrators, we now have the ability to precision tune the system. So at that, I'm going to thank you and hand it back to Carl.
Thank you very much, Dr. Brown. I think we're going to transition to a panel discussion talking a little bit about the future of documentation, but I wanted to see at this point whether there were any questions from the audience before we got into the panel. Yes?
My apologies. Yeah, these are actually, they're all attached. They're all on the SAEM website. You can do it, but that's...
That's also for Matt too, because when we looked at it, we saw the same thing. Our level 2 and level parent, they grew as a result. Was it because of the way we were capturing the documentation in terms of the coding? What changed in regards to that ultimately led to
Yeah, so a couple things. So one was we were able to get the data thanks to Ian, right? And then thanks to the kind of the multi-system teams that we kind of developed. And we actually went back to the coding company and looked and because we had the peer institutions, we knew where we were off the most. Like, why did we have so many level 3s compared to our peers? And we weren't shooting to be like number 1. We just wanted to be the median. And so then I knew, and I created like a list of what do I think the biggest opportunities are. Getting rid of level 2s, and then moving 3s to 4s or 5s, right? And then, going down this list. And so I tackled them one at a time. And so what we would do is, we'd find this like area, like level 3s, for example. I'd ask the coding company to do a double check on 100 level 3 charts, and then they would send them to me, and I would then do my own check on it using the ACEP grid. And then I found that a lot of, honestly, like 50% of them were coded incorrectly, even 75% of them. So then I would meet with them, I'd send them back to them and say, this is what I would code them, let's meet and talk about it. And we'd talk through them, and they would agree. And this helped highlight to Stanford that they needed emergency medicine expertise. And so we were able to actually bring in a different coding company. And believe it or not, they had emergency medicine expertise, but they were still making a lot of mistakes doing this same process. So finally, we ended on a third coding company with emergency medicine expertise. And this is the process that we underwent. But we actually had to sit down with our health system and go chart by chart. It was a lot of work, but I thought worth it.
One of the things that I've noticed, I just did a very recent audit, like charts for what company, and like invariably, part of the differential is like they're consistent themes. So I'm wondering if they're just not capturing or we're not documenting every time. It's like differential diagnosis comes up a ton.
The vast majority of the time, it was that there was, I would say 10% of the time we weren't documenting, 90% of the time they just were only looking at the final diagnosis and not paying attention to what was in the chart. So the prompts that Ian showed you are really important for your coding company because they're looking at each chart for about a minute to 2 minutes to code it. That's how long they take, about a minute. So or minute to 2. So having those prompts shows them the things that they need to tick box, and then hammering them on the differential diagnosis and that we actually thought about those. We're not just creating a list, but it's in there. And that was on the providers, and they did a great job.
Yeah, I think ours is the differential have similar. Actually see which ones we have. The other question I actually had is how are you accounting for APP charting?
So much of the data shown here is for our main ED. The documentation there is, we have very few APPs that work there. When we do have the APPs that work there, they're not independent. They're supervised and they're treated like residents, and it's oversigned by the attendings and getting full credit for it. It's just the way our systems work out. Our APPs work for a different entity, and thus the way the money flows, it's best if we oversign the charts.
Yeah.
I'm just curious to know if you did any SIM analyses when you were able to elevate level billing from 3 to 4, if it was because of patient complexity, data, or risk that like contributed to that level of billing.
Yeah, primarily that was around patient complexity and risk, right? Because these, what I call the central column, which is the data review, is pretty standardized and simple. Sorry, the question was, for the recording, the question was is what columns or what categories were the ones that really changed. The data complexity is pretty straightforward for the coders, but the differential diagnosis and the complexity of the thinking, right, is not as straightforward. So making sure that the providers are writing it in a way, not just putting a huge list, but actually explaining the things they're really thinking about. And then the other one is what Ian was talking about, which is the risk. And that's things like giving, it is much harder to discharge a chest pain patient than it is to admit a chest pain patient, right? So it is, right? Somebody comes in with chest pain, I gotta go through the whole conversation, I gotta make sure they got a follow-up plan, I gotta do all this, versus like kick them upstairs. So that component of saying like, I really considered admitting this patient, but I didn't, and here's why I didn't. The plan with the shared decision making. Writing that increases your risk dramatically. So doing that around medications when you could just give antibiotics because they want antibiotics, but you try to do the right thing and talk to the patient, not admitting them because trying to do what's better for the patient, which is to go home and do this outpatient workup, that sort of thing increases the risk. So it's those two columns.
Yeah, the data reviewed, I spoke to Jeff, our compliance guy. He's like, I don't even look at it when I review your charts. He's like, emergency physicians, you got this. Data review, that's not your problem. Otro preguntas? Other questions? Let's move over.
Yeah. And big shout out to Ian. Your templates are amazing, and we are very grateful for them. So I think this is the beginning of the panel section, where I think this is a perfect segue where we think about imagining the future state of documentation and billing, where we can use generative AI to make it a lot easier for all of us so we can spend more time with our friends and family. And so I'm Andy, I'm one of the Stanford faculty, and it is my pleasure to be both a moderator and panelist, and also introduce these amazing physician innovators. We have Dr. Fran Riley, Dev Dash, and Nick Ashenberg, all of whom are physician innovators. And so my first question, I'm going to start with a hard one, is what are the main challenges in the emergency department around documentation and billing that AI could solve?
I can start. So Andy and I work on a team that evaluates industry partnerships. We're located in the heart of Silicon Valley, so this is something that we like to do a lot. So theme of things that we've seen a lot are like AI scribes, right? So basically people who are software that aims to like ambiently listen to conversations and generate a note. And we've seen ones that generate pretty good HPIs. Like you just have a conversation with a patient regularly and it'll spit out text in roughly the vernacular that we talk about, like, oh, well, so age, patient history, et cetera, comes with it. And I think that's a really large opportunity because in addition to the convenience, you can imagine that having the script already makes it easier to then do things like capture critical care billing. The conversation content is there, so a lot of things that we might miss, like listening to the differential diagnosis and things like that, can then be captured. Like social determinants of health, which obviously is the new template, those are all things that can be easily captured. So that's the area that I'm excited about and hoping to see a lot of promise come.
I'm going to be a little bit of a contrarian here.
Oh.
So there's there's two kind of big comments I want to make. I've heard a lot about these kind of auto-documenting scribe companies, and historically there's always been a filter between what the patient says and what goes into the chart, and the filter is our clinical staff, so nurses or APPs, residents, and attendings. And what's happening with some of these AI scribe companies is, due to federal regulation, all of everything that's being collected at the bedside by these scribe companies, especially audio documentation, is all being stored in the cloud, and it is all discoverable. And so I think appropriately that makes a lot of physicians anxious, because what you don't want is like 5 years from now, somebody biopsies that chart record and says, oh, did you not hear the patient say here? Like, you clearly missed this, and your documentation doesn't reflect this. And now you're like, I don't even remember this. I don't even remember what I did yesterday. Like, I can't comment on 5 years ago. And so that appropriately causes anxiety among our physician group. And the second thing that I think, just to provide like kind of a CS and a BMI lens on this, is when we talk about generative AI, your personal, everything that you put in the chart that a model writes is still on you. So when you sign that note, you can't blame GPT or Claude for whatever mistakes it made. So you still have to review it. The first key element is your review cost has to be lower than your own personal generation cost. So it has to be easier and less time consuming, and hopefully less cognitively burdensome for you to review and note that an AI model writes for you than for you to write the note yourself. And oftentimes that is not the case. Imagine how long it takes with automated templates and shortcuts. You see an asthmatic and you give them prednisone and albuterol, and then you improve and then you send them home. Or they don't improve and you feel like you need to bring them into the hospital. That's a very short chart. It takes 45 seconds to document a chart like that. And how long does it take to review and note that an AI model writes? It might not be 45, it might be longer. So that's point number one. Point number two is, that ratio I've mentioned as, your review costs must be lower than your own personal generation costs. In my view, it should probably be an order of magnitude lower. And the reason for that is, when we talk about AI systems, we don't have the software tooling around these models to make your workflow efficient. So let me take like a non-healthcare example. Like, you go to ChatGPT today and say, I want a vacation, give me some vacation plans for Maui, and it can tell you what to do in Maui, right? But it's not going to buy your tickets for you and make a hotel reservation, get the rental car, and set up your vacation autoresponder. So in that sense, it's not really cutting down that much of your time. Similarly, when we talk about like models helping out with charts, it's not going to log on to Citrix, log on to Epic, write the note for you, then exit. We don't have that level of software tooling. So most of the time, those generative models, there isn't a huge time-saving component to it. It might write a note for you, but you still have to do all those tasks surrounding it.
Dr. Dash, are you saying that if we write something at the bottom of our note saying this note was written by generative AI, I take no responsibility, it may contain typos and dragonisms, that doesn't relieve us of legal responsibility?
It hasn't been tried yet, so you may be right. Maybe that's all it takes. Kind of like one of those like sent from my iPhone. Maybe that's the answer, I don't know.
I think Deb just had a lot of good points. I mean, I am a fan of the ambient AI companies, and I think they are going to hopefully improve our efficiency. in time spent in the note. But in terms of actual time saving, I think one future element is, I mean, we have very complex patients at Stanford, and it can take a lot of time to sit in front of the computer and try and digest what just happened to this heart and lung transplant patient who's on these immunosuppressants and was coming from other healthcare systems potentially and drove to Stanford. And the idea of a AI or machine learning breaking down a chart for us and providing us a few paragraph summary that we can quickly read. I mean, I was trained to look at discharge summaries, and that's what traditionally I do, but I think there's probably a future element of these electronic medical records to just summarize a patient's history into 3 paragraphs for us and potentially save us a lot of time.
Just to go back one quickly, I definitely agree there's a lot of corner cases that need to be addressed. By corner cases, I don't mean to diminish kind of the challenges you're talking about. I do think that we just started using some of these ambient listening, and there's a lot of work that needs to be done for sure. For us, you know, in terms of even piloting it, there's a lot of challenges in terms of like where the AI technology rests, like our server side, there's all kinds of challenges that we need to address. I think what I mean more is that this also presents a lot of opportunity. I agree there's like a lot of tasks that may not take over, but I think this is the beginning, I guess is what I'm saying, and there's, I think, a lot of opportunity for it.
Oh my God, thank you. Yeah, great responses, y'all. As we, the next question that I have for you is, you know, I've spent about 10 years in product development, and I feel like the Epic interface, it's okay, but could be better. And so how can we sort of reimagine, I guess, the interface for physicians as we incorporate AI tools? And I'm talking about specifically optimizing for the user interface and the user experience a la us as doctors.
Sure. I think one of the things that you know, and I've talked a lot at this conference already about sort of how much promise electronic health records had, and then how it's just completely failed to live up to any of that promise. Like there were all these editorials written when EHRs first came out that it was going to be so much more time with patients and so much easier for physicians, and then we all know that that clearly is not the case. And I think one of the limitations to that is we didn't have a lot of ongoing analysis as to how humans were, how physicians, how whoever was interfacing with the electronic health record, how they were doing it in real time, and really good ways of studying that and gathering that data. I think we're at a time now where we can better capture some of that data when we're talking about interfacing with AI systems or interfacing with the EHR. And I know Dr. Rose is doing some work about, and some other people at Stanford are doing some work about you know, how much time people spend in notes and how you interact with the EHR. But the hope is that as we deploy any of these new systems, we can get some more real-time feedback about how people are using it, take some notes from other product development areas where you do A/B testing and some other things to see what is going to be the optimum way of proceeding, and then hopefully we can gather some more real-time data that we're able to make adaptations to these interfaces a little bit more nimbly than get 10 years down the line and realize how terrible everything is, and then be entrenched in this system that's very hard to change.
As far as AI changing the interface with Epic, I have a couple thoughts on that. The first is replacement of ancillary services. Right now, for example, if you go to admit somebody, there's a case manager who reads your note, compares it to interqual, and then 3 days later it gives you feedback that you admitted to the wrong level of service. I see that having, and this is just ripe for AI to give us real-time feedback and information. Other things like registration, other ancillary services, I see going over a little more easily to an AI real-time interface. Also, I've been seeing a range of products that are not ready for prime time yet, but they're interesting, where essentially it's a widescreen sidebar, and as you start writing your note, it's reading through your note, and it gives you tips along the way, things that you need in order for either the next level of service, for billing. One of them that I looked at was really interesting, which looks at a legal database for most common legal pitfalls of malpractice for the note that you're writing. If you're writing, about a wound, maybe it's telling you a little bit about foreign bodies, and that you didn't document the fact that you looked for no retained foreign bodies in the wound, and it gives you real time on the side legal malpractice like information as you're typing, to telling you to address these to make sure you have a complete and full note. Like I say, I would have brought it to my colleagues if I thought it was ready yet. It was interesting, provocative, and 5 years from now, I think that getting that real-time feedback on the sidebar is going to be something that is just going to be expected in our notes.
And just to expand on that, that's fascinating. So as you're typing the note, is it based on chief complaint? And as you're, I guess, entering the HPI, is there text on the side that is actually kind of helping you think about things that we might miss?
Yeah. There's text on the side that comes up to reminders, and then you document. Look for foreign body, and then it will, ask you, did you document cellulitis, and so it helps reduce your legal burden. And it was a really easy sell to hospital administration because they want to reduce their malpractice risk. So it's the hospital brought it to us. They were really revving to decrease the amount of the risk, and they wanted to spend the money on this product. So it's when you have something with that kind of ROI, it's going to be easy to sell, and it's going to make rounds pretty soon.
Interesting. I mean, I imagine a future where there's almost like a chat bot or something that I noticed that the heart rate was recorded as 155 and AFib, and you gave IV diltiazem, but you did not bill for you did not do critical care billing. Did you forget, or do you think you need to? Whatever the language is, or automatically pulling in the the diagnosis of hyperkalemia when the potassium was 6.3 or something into your list of things. Well, I think in real time that could be the future.
That makes sense.
Yeah, I would like to caveat that I am a little bit of an AI evangelist, but I'm going to take a little another kind of contrarian take here.
I love Dev's hot takes. This is fantastic. This is what we need.
What's really good about this is generative AI, this is like version 1.0, and there are going to be better products that are going to come down the pipeline. And we're starting to figure out the pitfalls and potential use cases, which is awesome because I actually don't think the current architecture lends itself to truthiness. It lends itself to believable text. So the only thing these generative models do right now is predict the next word in sequence. They're not worried about being accurate, they're worried about being as believable as possible. So I tend to think of them as stochastic parrots. That doesn't mean they don't have value. It just means that we have to be careful about the workflows that we insert these models into. And the legal thing is like a perfect workflow, right? I mean, it's recommending things that if you added it in, is low risk to add it. Completely risk. It's not making clinical decisions for it, just telling you to consider certain things. But the second it goes into clinical decision support, there's definitely a world in which we can incorporate generative models into CDS, but we should be far more careful about the workflows that we insert into.
I am generally the opposite of a contrarian, but but in this light, I will say, I think the hardest challenge of current EHRs, so I used to work at Microsoft when I've been an engineer longer than I have been attending, and worked on a product that aimed to be an EHR competitor to Epic, worked with a lot of Epic engineers. I think the biggest problem with EHRs still is how they're built. The way that the EHRs are built makes it really hard to alter. The example I give to most people is if you look at how how iOS works and how well UX works there, it's completely different, right? Epic UX is from the 80s or 90s, and then your iPhone looks so much different. And one of the reasons is like from an engineering perspective, it's just so hard to make changes to the user experience compared to, for example, how iOS is built. A lot of it has to do with how Epic is built, the legacy systems, which makes it harder to change and things like that. And as much as I think there's so many cool opportunities for AI in terms of the like suggestions for medical legal, I think we've also seen ones that aim to partner with companies like UpToDate, apparently UpToDate didn't agree, but with clinical decision support. I think it'd be interesting to see if AI can tackle the problem of like the data structure such that it's easier to build modern UX on top of it.
Thank you guys all for such enlightening responses. It's 11:50, so we would be remiss not to get some audience questions, so maybe some people will trickle in, but in the meantime, do you guys have any questions about imagining the future of documentation and billing? All right, if not, well, thank you guys for attending, and we really appreciate you all coming on Friday. Thank you guys.